السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. يسعدني ويشرفني أن أكون تشيرمان في هذه الجلسة. Let us start this session about bariatric surgery. First speaker will be Professor Alessandro Palani from Italy. His talk will be about endoscopic gastric plication with both preliminary experience.
Thank you very much. Very happy to be here again with our Egyptian friends. Thank you very much again. Obesity is a progressive and chronic disease associated with high mortality and morbidity. Obesity is still the second cause of premature death in Europe and USA, and more or less 40% of adults are overweight and 13% of them with obesity. Obesity, we can prevent obesity, of course, by diet, by exercise, by medication, but now we have to fight against the main problem, such as the comorbidity. I'm speaking about diabetes, about cancer, about asthma, gallbladder disease, and so on. Of course, the first therapy the first approach for the obese patient must be the diet and the medication. But for severe obesity, there are many papers now which demonstrate that surgery is the best solution. Here is shown results about good results of surgery, about glucose tolerance, about diabetes, about BMI. Which is the risk of surgery? The risk of surgery seems to be not so high. It seems to be very low in terms of death and terms of complication. Anyway, the problem is that many obese people don't trust of bariatric surgery. This is the reason because there are some procedures improving now just for treat patient when surgery can be performed or when the patient don't want to be submitted to surgery. There are many studies. Here is I report what I already said about the 0.5% of obese patients who don't want to be submitted to surgery because of the risk of death. There are other, in this report, 85% of the obese patients would not choose surgery for themselves. And among US population, you can see that only 1% of the patients eligible for surgery are submitted to surgery. 99% don't want surgery or cannot have surgery also for other problems such as insurance or health system coverage and so on. So, and moreover, there is a gap between 30 to 40 of BMI when without any comorbidity, when there is no indication for surgical treatment. The guideline don't allow to perform in this patient surgery. And at the same time, this patient with severe obesity don't have good results if treated by medication or by diet. So there is a treatment gap where we have to choose what we can do. And in this patient can be considered an alternative procedure, such as pause, where pause could be a good approach for this patient. Pause has many contraindications, such as gastric or previous gastric esophageal surgery, such as gastroesophageal reflux, hiatal hernia, IBD, and so on, other different contraindication. Anyway, this procedure is permanent and durable. It's easy to perform. It takes no more than 20-40 minutes for each procedure. Reduces hunger signs and delay gastric emptying. We don't have any implant to remove after this kind of procedure. And moreover, it's a not invasive primary weight loss procedure. Must be performed, is performed endoscopically, but in general, under general anesthesia, and seems to guarantee very good results if compared with diet and exercise alone. In this animation, you can see that the fibroscope introduced by mouth in general anesthesia in the operating room. The first step is to make a full thickness application of the gastric fundus and application of the distal part of the gastric body. The topic is to reduce the sense of hunger with this full thickness applications of the fundus, and at the same time to delay the empty of the gastric emptying, just to slow the transit. At the end of the procedure, the stomach, the volume of the stomach is also reduced. Pediatric fibroscope and miniaturized instrument are introduced through disposable access instrument, and the first step is to make a full thickness application using a grasper, a disposable grasper, a sort of rotating grasper, which is called G-Links. We pull out, and then after pulling out all the wall, including serosa, and after that we can put some stitches, one stitches just with a special instrument, special needle holder, and it's fixed by anchor, and then you go to repeat this procedure for 4 or 5 times, creating a sort of row in the fundus gastric to reduce the volume, and with the target, as I told you before, to reduce the sense of hunger. As you can see, we continue this technique. I'm not endoscopist, I'm very sorry, but we have our unit, a group of endoscopists who perform this technique. We started to perform this technique. We perform two rows with 4 or 5 stitches for each row, and then after that we do the same procedure in the distal part of the gastric body. At the end of the procedure, as you can see, there is the stitch is a full thickness, create a full thickness folder with stitches serosa to serosa, as also demonstrated in the histological finding. But which is the evidence of this procedure? It's a new procedure, so there are not so many papers, most of them with very low evidence. There are two interesting prospective multi-center contour. One is European, called Milepost, and second one is American, called Essential. Okay. In the Milepost study, the Spanish, most of the centers are located in Spain. It's a study, it's a 12-month study, where in the pose is compared with diet and exercise alone, and the study concludes that pause patients had significantly greater weight loss than those treated by diet or exercise alone. And 6 and 12 months, at 6 and 12 months pause, subjects showed significant reduction in satiety parameters. The other study, the American one, with a follow-up of 12 months, conclude that clinically in the patient with the pause procedure, there is a significant weight loss at 12 months with... What happened? With the, I told you, I'm telling that the results of this study are similar to the other one. I'm director of a bariatric unit in Gorizia on the northeast of Italy. We are the National Center of Excellence for Bariatric Surgery. We have a very preliminary experience about this procedure. We started just at the end of the last year. We performed 6 procedures with the BMI including from 32 to 37, and the procedure took 75 minutes, and with the discharge the day after the procedure. The follow-up is very short, but it's interesting to observe that we have a decrease of reduction of BMI in 2 months of 2.5 and a reduction in excess weight lost in 2 months in 18 points. Without any complication, no reintervention, never we perform a reintervention, no prolonged length of stay, and no symptoms such as nausea or vomit. So difficult, of course, for me make a conclusion because of our very, very preliminary experience. What we think that this procedure can be considered very strongly in the treatment gap. It means the patient between 30 and 40 of BMI without comorbidity, when we for us it's very difficult to treat this kind of patients. They are not good for diet, and they are not good for surgery. This could be a good choice, in my opinion. Of course, it must be confirmed by other studies. Anyway, we have to think that this procedure needs a general anesthesia, and it must consider the cost of the procedure, and of course the data, which are very, very, very small at the time. Thank you very much.
Thank you so much, Dr. Balani. Just a question, did you do any sort of post-operative volumetry to check the volume of the remaining stomach after plication?
Sorry?
Did you check the volume of the stomach, the capacity of the stomach after the plication with the volumetry or something to check the remaining volume accommodating the stomach after plication?
We start to do it. It means that normally we do it also in bariatric surgery. Sorry, we do it in also in all bariatric surgery. On this patient, we didn't still have this the data about it, but it's surely we will do it in the next cases in the future. Anyway, the interesting thing in our experience, I speak about 4 cases, so I'm very sorry about the number of the cases. But what can I say? Personally, I detected the patients, and they are very well. They don't have any symptoms. But they cannot. They lose completely the sense of hunger. They don't want to eat. They don't need to eat. They don't think they have to eat. So this is for me, in my opinion, the important change. You know, this is the reason of the success of this procedure in my opinion.
Although the fundus is not removed, the fundus is still there but plicated. So the ghrelin secretion is not affected after plication like if it is resected in sleeve gastrectomy.
Of course.
Yeah, sure. Thank you.
Also, I want to ask for Dr. Salim. As regard the perforation of the fundus during application or post maneuver change of the vascularity at this site, and what about satiety for this patient? Because we are
What about? Sorry.
satiety after operation. Yeah.
Well, I don't, you know.
As regard the perforation, as regard the affection of the part which is stitched.
But we don't, in our experience, we don't, I don't know if I understand well the question. You ask me if for stitches in the for perforation.
Yes.
We don't have any perforation. I think it's in this the technique is not, you know, if we analyze the data, I don't see any situation which, such as perforation, we need to repair or something like this.
Okay. As regard the cases, it's 4 cases only.
Sorry?
4 cases. How many cases you did?
We need 6 cases.
6 cases.
Of course, as I have at the beginning.
I have a question, yes. By this procedure, you do cancellation for the fundus of the stomach. There is no fundus. The fundus is not present now after this procedure.
No, press the what?
The fundus of the stomach.
The fundus.
Yes, you do cancellation for the fundus. No fundus in the stomach.
No fundus is too much. I cannot say to no fundus, but you know, the applications of the fundus, it reduces the volume of the fundus.
Yes, but the fundus has a great role in the treatment of reflux. So, what about reflux after this operation?
There are no data about the reflux, but I don't think the same concept is about the sleeve gastrectomy, more or less. If we have reflux.
No. This is different from gastrectomy. So this is a normal stomach, not stomach with gastrectomy. So the fundus plays a great role in prevention of reflux. You do cancellation for the fundus, so reflux will be more.
Anyway, I think that if the study, preoperative study, we don't observe any symptom regarding reflux or hiatal urine or something like this, I don't believe that after this technique the reflux could be start.
Okay, thank you.
Any question from the floor people? Yes?
Sorry?
By the same technique, managing post-sleeve leakage, gastric fistula after sleeve. You have any experience in this?
No.
No, not applied in this leakage on this closure of the, no. What about thinking about plicating the whole lesser curve? Because now we are changing the concept of delayed gastric emptying to accelerating the gastric emptying to have a good loss weight. What about that? Thank you.
Okay. We don't have experience about it, Siri. In the future, of course, we have to check again. Maybe the next year when I come back again, I will tell you about this. Okay.
Okay, next, thank you. The next speaker, Dr. Ahmed Sabri, and for evaluation of of sleeve gastrectomy in supermorbid obesity. From Alexandria.
Bismillah ar-Rahman ar-Rahim. Dear Chairperson, dear my colleague and my professor, first I'd like to thank Egyptian Society of Surgery to give me the chance every year to present our work in Alexandria. And today I'd like to present the evaluation of laparoscopic sleeve gastrectomy in supermorbid obesity. This study of the thesis of master degree of Dr. Ahmed Mohammed Abu Magd under supervision of my dear colleague in my unit, Dr. Mohammed Asim, Dr. Hanin Haddad, and of course me. Since more than 8 years, we do laparoscopic sleeve gastrectomy as it was my MD thesis, and we progress more and more every year and every conference and present more cases. So we study and evaluate the sleeve gastrectomy in supermorbid obesity. What about the sleeve gastrectomy in this category? As you know, obesity has reached epidemic proportion globally with more than 1 billion adult overweight. It became a major contributor to the global burden of chronic disease and disability. A subgroup of severe obesity, body mass index more than 50, termed super obese. And another heavier subgroup of obesity, body mass index more than 60, termed super obesity, are the challenges of bariatric surgery. The population with super obesity increased by five times in the last decade and account for 30 to 50 of morbidly obese patients. The increasing demand of these patients in bariatric surgery centers is quite clear. What is the factor increasing the risk of surgery in super obesity? As you know, comorbidities such as hypertension, diabetes mellitus, obstructive sleep apnea, technical difficulties such as organomegaly, size and of greater momentum, increased intra-abdominal pressure, and excessive torque on the instruments. Also some physiological conditions such as limited disability or mobility. Laparoscopic sleeve gastrectomy was originally used as a first step in the term of super obesity patient before performing more complicated procedure such as Roux-en-Y gastric bypass. Their bariatric course was studied and showed satisfactory and promising result in super obese patients. So the aim of this study to evaluate sleeve gastrectomy in supermorbid obese patients as the first step of bariatric surgery regarding intraoperative challenges, the short-term outcome as regard mortality, morbidity, hospital stay, and quality of life. This study was carried out on 30 patients with super obesity admitted in upper GI surgery unit, Alexandria Main University Hospital, and followed up for 12 months. The inclusion criteria include age from 80 to 55 years and body mass index, of course, over 50 kilogram per meter square. Exclusion criteria: patient with severe systemic infection, endocrine disorder, active peptic ulcer disease, general contraindication of laparoscopy, major psychiatric disorder, patient with history of upper abdominal surgery. All of our patients have pre-operative assessment, including complete history taking, clinical examination, laboratory investigation, cardiovascular assessment, imaging study, upper GIT endoscopy, and pre-operative GVT prophylaxis. Intraoperative assessment include operative time, intraoperative technical difficulties, and intraoperative complications. Post-operative complications was recorded, including hemorrhage, fever, leakage, collection formation, and leukocytosis. Regarding preoperative analysis, there are in this study 10 male and 20 female with mean age about 40. The preoperative body mass index range from 52 to 56 kilogram per meter square. Preoperative comorbidity include diabetes mellitus, hypertension, lower limb venous insufficiency, and osteoarthritis. Operative analysis: the operative time ranged from 71 to 140, with range or mean 93 minutes. Intraoperative complication not happen in our study and our group of patients. Post-operative complications include hemorrhage occur in 3 patients, leakage, DVT, parietal hematoma, persistent vomiting, LH1 occur in 1 patient. This is the image of post-operative fistula and leakage. This image of parietal hematoma. Hospital stay range from 2 days to 12 days with mean 4.5 days. Follow up for 1 year, there are significant reduction of body mass index after 6 months and 1 year. Post-operative excess weight loss percentage is significantly improved and increased after 6 months and 1 month as shown in this diagram. So the success rate occurred in 27 patients of our studied group. There are significant resolution of comorbidities such as diabetes mellitus, hypertension, and osteoarthritis after follow-up of our patients. Post-operative quality of life, most of our patients was good and very good quality of life by assessment score. And this is the image of our hero after 1 year of follow-up. So conclusions, laparoscopic gastrectomy can be performed in super obese patients safely with no increased risk of intraoperative complications. Laparoscopic sleeve gastrectomy can be performed in super obese patients with percentage of excess weight loss and success rate superior to other restrictive procedure and comparable to malabsorptive procedures. Obstructive sleep apnea and controlled hypertension are the major risk factor for post-operative bleeding. Sleeve gastrectomy can be performed in super obese patients with no increased risk of leakage. Sleeve gastrectomy is effective bariatric and metabolic surgery regarding amelioration of comorbidity. Quality of life is significantly improved in super obese patients undergoing sleeve gastrectomy. So we can take home message, laparoscopic sleeve gastrectomy could be used as a safe stand-alone surgery for successful weight loss in super obesity. And add to your calendar, Surgery Alex, 2019 in Hilton Alexandria Green Plaza. And thank you.
Thank you very much, Professor Ahmed Sabri. Very nice presentation. Any questions? May I have one question? I saw the osteoarthritis is still persistent in your diagram.
No, it's improved. Only one patient had before osteoarthritis and improved after weight loss.
It doesn't improve.
I think improved, okay.
It doesn't improve post-operatively.
Post-operatively?
Yes.
Okay, I will revise the presentation, and I think it's improved.
The follow-up only for 1 year or for how long?
1 year, yes.
1 year.
Yes.
What do you expect after 3, 4, 5 years?
Okay, as I presented last year in an ESS conference, I have a paper printed and published in ESS journal about volumetric study of sleeve gastrectomy after 2 years of sleeve gastrectomy. There are significant increase in pouch or volumetric pouch of our patient with failure rate up to 70%. So first step, a sleeve gastrectomy, as you know, and as all floor know, that it has what is called the honeymoon, yes, which extended from 18 months up to 2 years, and then we can expect failure and maybe need another step. So yes. I think by next years, the sleeve gastrectomy will come back as a first step of malabsorptive procedure.
I think sleeve gastrectomy alone, after 3 years, it needs another procedure.
So we can consider later on, we can consider sleeve gastrectomy is a first step as prescribed in 2004 as a first step of Scopinaro or malabsorptive procedure.
Do you advise with the sleeve from the start?
So I think sleeve the indication is clear. Sleeve gastrectomy is indicated and clear in low body mass index obese patient, low body mass index from 40 to say 50, super morbid obese who unfit for surgery for prolonged or longer duration of operation. So I can do sleeve gastrectomy as a first step with satisfactory result after 1 or 2 years. Finally, it should be concise to bulk eater, not sweet eater. Bulk eater person, obese, who take more and more food. I think restrictive procedure, especially sleeve gastrectomy, is suitable for him. So sweet eater, don't do sleeve gastrectomy. Diabetic patient, don't do the sleeve gastrectomy. So the indication is clear. Low body mass index, unfit for prolonged surgery, bulk eater patient.
But do you think you can tell the patient then maybe after 3 or 4 years we need another step?
Of course,
From the start?
I think my patient, our unit patient usually may by high percentage need another session for correction or revision.
Okay, thank you very
Okay,
much.
thank you.
Any question from the floor? Shukran.
Thank you, dear.
Next speaker will be Professor Ala Suefi from Minya. His talk will be on the outcome of single anastomosis sleeves jejunal bypass as a treatment for morbid obesity, 2-year follow-up.
Mr. Chairman, my dear professor and colleagues, Assalamu alaikum. My talk today about the outcome of single anastomosis sleeve jejunal bypass as a treatment for morbid obesity. What is the meaning of single anastomosis sleeve jejunal bypass procedure? It is classically sleeve gastrectomy followed by loop anastomosis of jejunal about 2 meters from the DG. The questions that may jump to the mind: why we need for single anastomosis sleeve jejunal bypass, in spite we have established procedure like sleeve gastrectomy, Roux-en-Y gastric bypass, and MGB. Laparoscopic Roux-en-Y gastric bypass is still the gold standard bariatric procedure, but as we know, it is complex, technically demanding, and if failed, what is the revisional surgery? Also, sleeve is simple, effective, and the most common bariatric procedure done nowadays. But as we know, and reported in this study, published in the surgery for obesity and rich surgery, that the gastric pouch after 2 or 3 years increased to up 250 millimeter, which mean weight regain. Also in this study, which was long-term study for sleeve gastrectomy, they found that the conversion or redo surgery after sleeve gastrectomy may reach up to 25%. As regard mini gastric bypass, in spite is easier technique and preferred by some surgeon to Roux-en-Y gastric bypass with very good long-term result. But it is associated usually by malnutrition. And in this study, comparing Roux-en-Y gastric bypass versus mini gastric bypass, they found that hemoglobin level and microvascular volume is very low in mini gastric bypass compared to Roux-en-Y gastric bypass, and this effect persisted up to 5 years. In bypass surgery in general, the duodenum and upper jejunum is bypassed, so water-soluble vitamins, ferrous and calcium, which its main site of absorption is the duodenum and jejunum, is affected, which lead to malnutrition. Also, another important issue to be discussed in bypass surgery that when the patient develops obstructive jaundice, the classic transoral ERCP isn't possible. And we need to special technique like balloon endoscopic ERCP, laparoscopic transcystic combile duct exploration, BTC, EOS guided transhepatic ERCP, laparoscopic transgastric ERCP. But this technique is technically demanding, not available in all institutions, and also it has a complication rate may reach to 17%, and success rate maximum 70%. So what? As the Plato say, necessity is the mother of invention, which enforced Santori in 2012 to develop his operation, which is a sleeve gastrectomy with transit palpitation. He tried to keep pass to the duodenum to decrease the malnutrition and to keep pass for ERCP if the patient develops obstructive jaundice. But the technique was Roux-en-Y sleeve ileal bypass, which was also technically demanding and lengthy, which enforced me in 2013 to develop his loop bipartition or sleeve, single and smooth sleeve ileal bypass. In our study, we shift the anastomosis of classic SASI to a sleeve jejunal bypass to test the effect of this procedure on the BMI, nutrition deficiency, and comorbidity. This study is a prospective cohort study conducted in many university hospitals between April 2016 to December 2018. It includes about 150 patients. All patients underwent single anastomosis sleeve jejunal bypass with biliary rim about 2 meters. 90% of patients complete follow-up for 2 years. Patient evaluated as regard BMI, complication, nutrition status, and comorbidity. Enter. This short video shows the procedure of single anastomosis sleeve jejunal bypass. We begin as standard sleeve gastrectomy by dissecting the stomach from greater curvature and continue up to reach short gastric. And we must cautious in this step as planing here is difficult to be controlled. As you continue downward to separate the stomach from greater curvature, the trick here will not stop as usual in sleeve gastrectomy at about 6 meters from the pylorus, but we continue the section to reach the pylorus itself. As you continue sleeve gastrectomy as usual, using 36 bougie. Then we count about 2 meters from DG to be anastomosis to the sleeve. Then the sleeve is anastomosis to the jejunum. First step is to take stay suture to fix the jejunum to the pylorus itself. The trick in also the anastomosis is dependent between the sleeve at the greater curvature and the jejunum. The defect closed as usual in 2 layers. Finally, leak test is done. Now we have two pathways, one through the duodenum and upper jejunum, and the other pass to the jejunum. The mean age for patient was about 30 years old. The mean BMI was about 44. 35 patients have type 2 diabetes, and 47 patients were hypertensive. One case developed post-operative bleeding and need 4 lab leaks operation. One case developed gastric leak and managed by endoscopic internal drainage using pigtail. 5 cases developed biliary gastritis and managed by conservative treatment. One case developed pulmonary embolism and managed medically. Percentage of excess weight loss was 18 بس. Start. Just 1 minute. Percentage of this weight loss reached 85% at 1 year, and blood glucose returned to normal within 2 months after surgery in all diabetic patients. Hypertension remitted in about 90% of hypertensive patients, and after 1 year, we weaned the patient from 4 regimen multivitamin to just 1 regimen multivitamin without apparent nutritional deficiency. So we can conclude that laparoscopic single anastomosis sleeve jejunal bypass is effective, safe, and simple procedure for treatment of morbid obesity and its comorbidity, but long-term result is still under evaluation. Thank you.
Thank you so much, Dr. Ala. How long was the follow-up period in your series?
It's a study about 2.5 years. About 90% of patients followed for at least 1.5 years.
We'll ask you the same question as Dr. Ahmed in the previous presentation. How did you find your tube, the sleeve tube, after 2 years from the last operation?
Truly, I don't do volumetry.
You didn't do a volumetry?
No.
Yes, because I think the results, and this is the objective of your study.
Yes, avoid.
You decrease the pressure inside
Yes.
the sleeve tube, so the distensibility and the regain of weight will be less. I think
Yes,
this is
I add some sort of malabsorptive, and in the same time, I prevent the expansion of the pouch post-operative.
Thank you, Dr. Ala. This procedure is very good for continuous presentation of the result of sleeve for many years, and there is no any recurrence of dilatation or obesity. But what about the dumping process of this?
Dumping not considered complication by bariatric surgeon, as it may allow patient to select his food and avoid the sweaty and fatty food, which favor the maintenance of weight loss. So we consider as a bariatric surgeon, dumping is a good thing, not a bad thing, like in general surgery.
You didn't solve it.
The patient avoid taking bulky meal, avoid taking a sweaty meal and fatty meal.
But there is no any surgical procedures to decrease or prevent?
We don't need already dumping occur in some cases, but we didn't consider it as a complication, and the patient managed by changing his food habit.
Yani all your patient developed the dumping?
No. Some I don't know the percentage per se, but some patient develop dumping, but I don't consider it as a complication. But something we need to enforce the patient to select his diet.
If your anastomosis is more up in the near to the fundus, it will decrease the dumping and also the same result.
I do sleeve gastrectomy and add to it some sort of bypass. The main
if you do the bypass more up.
So it's another procedure, not sleeve bypass, maybe Roux-en-Y gastric bypass or MBG. But our technique is sleeve gastrectomy plus jejunal bypass.
Okay.
Thank you. Any question from the floor?
Yes. I think there is, I agree completely with you that dumping is a therapeutic, not a complication. But still an issue of the same as with Rutledge about mini gastric bypass. There is still a limb of biliary gastritis.
Yes.
And when we do a scintigraphic study of the stomach, the main flow will be through the gastrojejunum, not through the pylorus. So it is some sort of mini bypass. Did you measure the whole length of the intestines before anastomosis?
Truly no. Truly no. I count from DG about 2
Yes,
meters.
you don't know the distal limb.
I
And
don't
this
truly,
may
truly,
produce
yes,
some problems.
there's the idea of Dr. Scoponaro. In every bypass surgery, we must count from LC conjunction
Yes,
to yes.
nowadays because the length is variable. But about gastritis, biliary gastritis or biliary?
5 patients develop severe biliary gastritis, and I complaining with them. But after about 2 weeks, the problem is improved by conservative management.
You did change any size of the stoma on the anastomosis?
No,
Affect
conservative
this?
management, modification of food, gastrofeed, Nexium. No need for
No malnutrition, no patient with short elementary
No. But I shift from 4 regimen vitamin to just 1 regimen vitamin after 1 year.
Thank you.
Thank you, Dr. Ala.
Thank you, Dr. Ala. May I ask about Dr. Hamoud Hamid from Syria? Is here? No. Also, Dr. Hussam El-Banna from Mansoura. Not here? So will be the next speaker will be Dr. Rosanna Berta from Italy. Yes, welcome. Her talk will be about revisional bariatric surgery for failure or complications.
Thank you to all the organization for this invitation, the president and the secretary. I work in Pisa, in Italy, and I present our experience of our center on revisional bariatric surgery. Bariatric procedures are increasing in all Western and Middle East countries. And consequently, revisional bariatric surgery is increasing. And the incidence is about 3 and 60%, depending upon the type of primary bariatric surgery. And indication for revisional surgery are weight loss failure, weight regain, long-term complication, and loss of quality of life. Weight regain is the most frequent cause of revisional surgery, and occurs when the first operation failed, when excess weight loss is less than when the first operation doesn't fail and excess weight loss is more than 50%, and then the patient gain weight. And in literature, the incidence is different in different kind of operation, is more frequent in gastric bending, in sleeve gastrectomy, and in vertical gastroplasty, and is less frequent in gastric bypass and DPD. In our series that is not updated with the mean follow-up, is 47% in gastric bending, is 18-20 after 4 years, but our data are getting worse in sleeve gastrectomy. We have more weight regain, and is around 15% in gastric bypass. And all the patients before the operation are submitted to examination of BMI, signs and symptoms of malabsorption, vomiting, symptoms of dysmotility, acid hypersecretion, are submitted to psychiatric evaluation. It's very important to obtain a report of the primary bariatric operation, and the patient are submitted to barium swallow or CT with 3D reconstruction, endoscopic examination, and pH and biometry. These are images of barium swallow in gastric bending, and with this radiograph we can discern if the dilated gastric pouch is due to a slippage of the band, or due to obstruction of the outlet of the band. So in the second case you can desufflate the band and finish. In the first case, you must operate this patient. And with the barium swallow, you can observe stricture, the site of stricture in sleeve gastrectomy. You can see these are technical problems, errors during the execution of the sleeve gastrectomy. You can see stenosis of the incisura or the esophagogastric junction on the body, and you can observe the image of the endoscopy and the intraoperative view. And all the patients with reflux are submitted to pH and biometry, and you can see an exam of a patient, or pH metry and biometry of a patient before a sleeve gastrectomy. You can see that this patient has no reflux before the operation, and 1 year after the sleeve gastrectomy, you can see this pathological pH metry. And sometimes the endoscopic exam is not enough to observe some alteration of the anatomy of the sleeve gastrectomy. So we perform the reconstruction, 3D reconstruction of the sleeve, and you can see a kinking of a sleeve and a twisting of the sleeve that sometimes are at the basis of the esophageal reflux or dysmotility in a patient operated by sleeve gastrectomy. These are other images. You can see a kinking of a sleeve gastrectomy. We analyze our data, and we evaluate 159 patients, but these data are not updated. We have 80 more patients we have operated in the last year. And we can see that the BMI at the time of revision was 43. At the time of the primary operation was 47. And our mean follow-up is 29 months. Now is longer. And the primary operation submitted to revision, the most frequent submitted to revision was gastric bending, followed by BPD that is very frequent in Italy, but sleeve gastrectomy is growing up. We are converting sleeve, and we have to add the conversion of OAGB. We have 2 conversion of 1 anastomosis gastric bypass now. The most frequent cause of reason for revisional surgery is weight regain, followed by weight loss failure that occurred primarily in bending, in bend, and in Roux-en-Y gastric bypass. Then we operated some patients for gastroesophageal reflux, main in patient with gastric bending and sleeve gastrectomy. And the numbers of patients with this sleeve gastrectomy that we are converting is growing from sleeve gastrectomy. And we operated 24 patients with BPD for malabsorption. The most frequent operation we use to convert and correct the first operation was, as you can see in this flow chart that is very difficult, is Roux-en-Y gastric bypass. And our results are that when we performed the rebending, our results were really poor. If you see the red area, the first rectangular represents the BMI at the time of the first operation, and the second area represents the BMI at the time of reoperation, of rebending in this case, and you can see that the BMI didn't change after the rebending. So the results of the rebending is really poor. We abandoned this kind of correction, and all the patients were submitted to a Roux-en-Y gastric bypass. And we have no great result in conversion from HB to sleeve gastrectomy. The excess weight loss after the conversion is not so enthusiastic. So we think that is not a good choice to perform a restrictive procedure after the primary restrictive procedure. Excellent is the result of Roux-en-Y gastric, but the conversion from gastric bending to Roux-en-Y gastric bypass. You can see that the BMI is around 44 at the time of the revisional surgery, and is 31 after 2 years of follow-up. And good result in conversion from VBG to Roux-en-Y gastric bypass, and from sleeve to Roux-en-Y gastric bypass, when we have weight regain, and we have good results in reflux, in controlled reflux. And we have only 2 cases of conversion from the sleeve gastrectomy to duodenal switch. But the results are very encouraging. Now we're starting to move from sleeve gastrectomy to the SADI procedure. And we have 9 cases. Sorry, go ahead. Can I go ahead? Go to the conclusion. We have performed almost 80% of our procedure by laparoscopy, but we have high rates of conversion to the laparotomic approach. These are our complications, and we can see that we have 4% of leaks. We have marginal ulcers, and incisional hernia are the most frequent complication. And comparing the complication of a primary Roux-en-Y gastric bypass on almost 1,000 operations to our results, a complication of Roux-en-Y gastric bypass, you can see that we have a mortality that is 3-folds in conversion, and leaks that are 5-folds more frequent in leaks. So our conclusion are that revisional bariatric surgery is widely increasing because of long-term failure or complication of primary procedure. Traditional laparotomic approach for revisional cases is needed in about 20% of cases. Accurate study of failed and complicated patients should be done prior to revisional. Conversion to Roux-en-Y gastric bypass is the most diffuse revisional procedure after primary filed restrictive procedure. Pouch revision and bending can be considered a safe and effective rescue procedure when Roux-en-Y gastric bypass fails. We use the phobia ring and resize the pouch and gastrojejunal anastomosis. Complication rate after revisional bariatric surgery is significantly higher when compared to primary surgery. Thank you.
Thank you so much, Dr. Berta. You mentioned in the last statement that the complication rate is more, of course, after the revisional surgery. But about the incidence of the regain of weight compared to the first time regain?
The weight regain
Yes.
after the second.
After the second operation.
We have a follow-up of almost 5 years after the first procedure, but we must registrate it, but because after 5 years we can see the result of gastric bypass that is similar of the primary gastric bypass. But I think that is in our hands is excellent because we have only 20% of weight regain because dilated pouch or in patients that are sweet eaters. And so sometimes we have to reduce again the pouch. If we have a patient that had prior bending, so sometimes we have performed the stitch, endoscopic stitch of the gastric anastomosis, but after 1 year we have again a gastric anastomosis open. So I think that's the second operation must be the last operation, and then some patients we have to correct the style of life, and they need more psychiatric consulting and see another style of life.
Okay. Any question?
Thank you, Dr. Perpa, but I want to ask you that you mean by your this work is very good, that you are change the problem after the first treatment for obesity, but you treat by another method for also bariatric improvement. How you remove the problem by another problem?
I think that every patient is different, so we have to understand what was wrong in the first operation. We don't use any more bend, so we perform gastric bypass. We use a longer biliopancreatic limb, not 2 meters, but 150 centimeters, and we perform a small pouch. And I think that we try to perform the first operation better for the patient.
Yes, but in the gastric band, you did for this patient sleeve, I think.
Yes, sometimes we have to perform sleeve gastrectomy,
Yes.
but it's not our preferred operation. Every time we prefer to perform gastric bypass. In super obese patient, we perform sleeve gastrectomy and then duodenal switch if we have not a good result after 5 years.
Yes, okay, thank you.
Any more questions? Thank you so much, Dr. Berta. Next speaker, Dr. Mina Helmi. Mina, M.I. مش قلنا كده مرة فاتت from SWAG, and he will speak about staple line reinforcement during laparoscopic sleeve gastrectomy.
Staple line reinforcement during laparoscopic sleeve gastrectomy, our early experience in Swag University Hospital. Obesity is becoming a worldwide problem and can increase the risk of related disease, including hypertension, diabetes, sleep apnea, etc. All are comorbidities of obesity. Bariatric surgery has been recognized as the most effective long-term treatment modality for severe obesity. Among various bariatric procedures, laparoscopic sleeve gastrectomy has rapidly gained popularity to become the most frequently performed worldwide. Due to long staple lines, the main complication of laparoscopic sleeve gastrectomy are post-operative hemorrhage and gastric leak. Staple line reinforcement is not well standardized and involves different options over sewing of staple line, application of buttressing or roofing material, including specific biologic tissue and hemostatic sealant. Staple line reinforcement is extensively debated and highly recommended by most surgeons in an attempt to reduce post-operative complication. However, there is some disadvantage in this method. For example, ischemic event, leakage from tear by stitch, excessive rotation of mucosal end, staple deformation, and prolonged surgery. This study was carried out to estimate the effect of staple line reinforcement and to help surgeons make a better decision in management of the staple line during laparoscopic sleeve gastrectomy. Candidate for surgery, including age from 18 to 65, BMI more than 40, BMI more than 35 with comorbidity, well-informed and motivated patient. No contraindication for bariatric surgery. However, relative contraindication, including contraindication to general anesthesia, pregnancy, severe psychiatric disorder, uncontrolled drugs, active cancer, and etc. In the period between 2016 to 2018, 60 patients suffering from morbid obesity scheduled for laparoscopic sleeve gastrectomy were enrolled for this study at Sohaig University Hospital, Egypt. Patients were divided randomly into two groups. First one, including 30 patients, underwent laparoscopic sleeve gastrectomy with oversewing of the staple line with running suture. The other group underwent laparoscopic sleeve gastrectomy without staple line reinforcement. Only additional crippling of the bleeding point of the staple line was instated in 16 cases, and the remainder didn't require overclipping. All patients subjected for detailed history and clinical examination, also routine lab and nutrient screening, abdominal ultrasound, cardiopulmonary evaluation, gastrointestinal evaluation, endocrine and lower limb Doppler ultrasound. After written informed consent taken from all patients, all operative steps, expected results, side effects, and operative complication has been explained to all participants, and operations are performed under general anesthesia. Position for bariatric surgery, either the surgeon stand for the right of the patient or in between the leg. This was the preferable side to us. Trocar side. Division of the greater omentum. Division of the stomach. This is a staple line and reinforcement and extraction of the specimen. This video, short video, show first division of the greater omentum. As usual in laparoscopic sleeve gastrectomy. Then division of the stomach. And then reinforcement of staple line using running suture like this and continue the same steps of laparoscopic sleeve gastrectomy. This specimen after extraction. Dietary style after surgery. First week clear liquid fluid, second week full liquid, and third week pure diet, fourth week soft food, and then regular diet. Demographic data, no significant difference between group, while operative time was statistically significant difference between both. No intraoperative complication and no mortality. No case with leak or stenosis. Staple line bleeding was detected post-operative, only one case. Length of hospital stay was somewhat longer in non-reinforcement group and ranged from 1 to 4 days, except the case show post-operative bleeding long for 7 days. Conclusion, staple line reinforcement during laparoscopic sleeve gastrectomy with oversewing running suture is an unrewarding surgical procedure with the sole effect of prolonging the operative time, without significant effect on post-operative leak or bleed. Used by surgeon as a personal performance and as security shield rather than of its advantage. Thank you.
Thank you for your nice talk, Dr. Mina. There is a question from the floor. Yes. تفضل.
My name is Abdurrahman from Mars Matruh. I am asking about did we need this swing with this nowadays? We're using the powered staplers, which is very strong and quality is high now. I think with this stapler we don't need overswing.
Again, man. You support my talk?
Yes.
Yes?
Thank you very much.
You support my talk. Thank you.
اسأل عليك سعادتك.
Last speaker will be Mohammed Abdel Majid and Shams. He is available? ما جاش؟ طب any question from the floor?
Any experience in bariatric?
Okay, thank you very much. The end of the session now?
Session is finished.
ما هو ده session last session. مفيش حاجة تاني.
لا خلاص last.
شكرا.
شكرا جزيلا.